Okay, so coma overall is an unconscious state where the patient won't initiate any purposeful actions or movements. So that's specifically coma as opposed to uptentation or stupor. Dr. Zazilia said you don't have to know the specifics for what makes those things different, but in general, coma is when the patient's not initiating anything voluntarily. So they cannot be aroused no matter what you're doing to them. You can give them a sternal rub, something painful, and they don't react, or at least not in a purposeful way. So coma can progress to either having a slow recovery. You expect to have recovery over the span of 2 to 4 weeks. They can die. That's always a possibility too. Or they can go into a persistent vegetative state, which you'll remember is a state where there's a circadian rhythm, there's apparent actions that are happening, but none of the actions are actually purposeful or meaningfully responding to any external stimuli that are around them. So for coma, you have to localize where the coma is going on, and there's really 2 main important places where you can localize the coma. There's some other places where it could potentially cause a coma more focally, but these are really the 2 classic ones that you guys should know. So it's either the bilateral cerebral hemispheres, you can't just have one hemisphere, but you have to have both, or it can be the reticular activating system that's largely in the brainstem. So for what can cause coma, it differs depending on if it's in the cortex or if it's in the brainstem. So if something's affecting both of the hemispheres of the brain, you generally think about things that are happening diffusely throughout the brain. So that can be a systemic problem that's causing inabilities for cells to function normally. So if you had hypoxia particularly bad, for example, from lung pathology, if you had inability to have proper circulation from the heart not pumping properly, if you had liver problems, you had buildup of nitrogenous waste products, that can cause it. If you had really bad kidney failure and you're having really bad uremia, that can cause it. One of the most important things to consider when a patient comes in acutely with coma is, are they an insulin-dependent diabetic? Did they take too much insulin and now they have too low blood sugar for their brain to function properly? Do they have really bad electrolyte or osmolality problems that could affect how the neurons are firing? And are they taking any CNS depressant drugs? Like, did they overdose on alcohol? Did they overdose on opioids? Aside from that, you can also have pathology that's more localized to the brain as well. So it could be that they have a global anoxic brain injury if their heart stopped beating for a while. It could be that they have subarachnoid hemorrhage that's diffusely irritating the brain, both hemispheres at the same time. It could be that they have a large mass lesion where if it has enough mass effect and it's causing damage to both hemispheres at the same time, can produce a coma. And then you can also have widespread white matter injury that will produce something similar to affecting the cortex. So now talking about the reticular activating system that's in the brainstem and part of the diencephalon. So for that, you think generally more about focal causes. Something can be small there and produce a coma. So here's just some examples. You can have posterior circulation strokes that happen to hit right there. You can get vascular malformations like Greg talked about. You can get a mass lesion that's right there that can press on a part of the reticular activating system. Something a little bit bigger would be a herniation syndrome that causes coma. So when you're trying to localize in coma, you can think about these different things of what it could be, and obviously you want to do lab testing to see what it could be, but it's also important that you do a good exam. You can't do the normal neurologic exam on these patients. They're not responding the same way that most of your patients are. They're not following your eyes for an age test. So what you can do is different tests that don't rely on the patient voluntarily participating in the exam. So people talk about breathing. In general, it's not that good at localizing. It just tends to be abnormal. However, pupil size, pupil reactivity are useful. That's why we talked about them. Eye movements are useful. That's why we talked about it. And motor response to noxious stimulation. So you hear about decorticate, decerebrate posturing. The important thing to know is just posturing, that there's movements of the arms in a stereotyped way that when you give a noxious stimulus, they always move it the same way. And it's not voluntary. It's not them reacting to you, trying to push you away. They're not pulling away from you. They're just doing the same thing again and again. The mnemonic I like to use for remembering decorticate versus decerebrate is that decorticate, they bring their arms into their core. But overall, it's not that good of a localization to be able to say it's decorticate versus decerebrate. So another factor too is both for motor and for reflexes is there's laterality to what you see. That if there's one side, you see differences in the other that helps to support a structural cause that's causing the coma. So now that we've talked about pupillary reactivity and some of the pathways involved in the parasympathetics for being able to respond to light, let's talk about how different localizations of coma produce changes to the pupillary size at baseline and how the pupils respond to light. So when you have both hemispheres at the same time, like from a metabolic cause, the pupils can be normal, usually, sometimes small. What's a reason why the pupils can be small from a systemic cause of coma? Yep, opioids. So opioids will make your pupils small. And the pupils end up being reactive to light. Why would they be reactive to light? Yeah, the brainstem's just fine. The midbrain's working just okay. Now for the diencephalon, the pupillary size is small. Why would they be small when it's due to the diencephalon being injured? Hypothalamus and thalamus. Yes, where did the sympathetics start? Hypothalamus. So that's the important key fact, that when you get damage to the diencephalon causing coma, it's often going to be causing damage to the sympathetics there too, so you lose the sympathetic drive, and it's only parasympathetics, so that makes the pupils small. And the pupils are still reactive. Again, the midbrain's doing just fine. Now, I'm going to go over the terms for tectum and tegmentum because I always get this confused. So tegmentum is most of the midbrain that's not the peduncles, not the tectum, I'd say. The tectum's the part that's more dorsal, the top that's past the cerebral aqueduct. So you can differentiate whether or not something's in the tegmentum versus the tectum for causing coma. So if the lesion's in the tegmentum, in the main part of the midbrain, then the pupillary size is usually normal. The reason why it can be normal, a way I like to think about it, is that it's interrupting both the parasympathetics and the sympathetics at the same time, so it kind of cancels out. And it's fixed because you're interrupting the pupillary response to light from the parasympathetics. For the tectum, it can be normal or large potentially because you're interrupting the parasympathetics without affecting the sympathetics. And you can also see hippus with the eyes, where even though they're not responding to light, they're just intermittently dilating and contracting. If you're just affecting a peripheral cranial nerve, obviously just a peripheral cranial nerve 3 injury wouldn't be causing coma. There has to be something else involved too. But if you were to try to localize to there for the reason why you have pupillary abnormalities, then you'd see a large unilateral pupillary dilation, and then it would also be fixed on that side because you're interrupting the parasympathetics running on the outside of cranial nerve 3. And then lastly, for the pons, ends up being pinpoint and small pupils because they're just impairing the sympathetics running through the pons, getting down before they get to T1 in the spinal cord. And the pupils are reactive if you look really carefully. They're small, but if you were to shine light in them and look with a magnifying glass, you can see that they're reacting. Okay, so when you're examining a patient with coma and you're trying to check their eye movements, we already talked about how you can't do an H test on them, so you can do different exam maneuvers to be able to see their responses to other stimuli that normally cause eye movements. So one example of that is the oculocephalic response, which is where you take the patient's heads, you prop their eyelids open, and you turn them fast. And you see how the eyes respond to that. And this is something that you have to do in patients who are comatose. If you do it in awake people, they can suppress it. They don't have to have this reaction. But in someone who's comatose but doesn't have structural damage, what will happen is their head will turn and their eyes will turn the opposite direction for the way you turn their head. And I like to think of that as like trying to stabilize where they were looking before from that sudden deviation. I'm just going to talk about bilateral abducens nuclei damage in order to simplify things. But when you have those structures damaged, then they're not going to be initiating that to be able to have that movement because you need that in order to make that movement. Whereas if you just have the MOF or the oculomotor nucleus injured, then only one of the eyes is not going to be able to react because the other one's doing just fine, trucking along, but the other one doesn't get the signal that it needs to move. So aside from that, there's also the oculovestibular response, which is something that you don't want to do in awake people because they'll puke. But in a patient who's comatose, it can be useful for localizing. You put cold water into one of the patient's ears, and that confuses the vestibular system. It makes us think that there's movement and tricks it into having some eye movement. So if there's no damage to the oculomotor pathways, then you first see a slow deviation towards the side that's irrigated, and then it snaps back. And that's the nystagmus, that's snapping back in the opposite direction of the side that you irrigated. And that snapping back happens because of the frontal eye fields realizing, hold up, something's not right here. They send a signal down and tell it to have that nystagmus back. And it'll happen over and over again, so slow, snap back, slow, snap back. So you can use this for localizing too. If it's above the midbrain, you're not interrupting those structures. If you're disrupting the frontal eye fields, you might not see the nystagmus back, but it should still deviate. The slow deviation is what you're looking for here. If it's affecting the cranial nerve 3 nucleus, or if it's affecting the MLF, then it's only going to do one eye, like we talked about before. Abducens is sending its signal out to the abducens nerve, and the lateral rectus is firing. And if there's a lesion affecting the abducens nuclei, then they're not moving at all because you need those in order to initiate the movements.